According to the Centers for Disease Control and Prevention, 75 to 85% of people who become infected with hepatitis C virus develop chronic infection.
Today on Health Talk, our guest will discuss hepatitis C, explaining who's at risk and what treatments are available.
So stay tuned, we're up next.
Hello, I'm Dr. Eric Mazur.
And I'm Dr. Andrea Peterson. Today we're going to talk about hepatitis C with Dr. William Hale. He's the director of the Digestive Diseases Center at Norwalk Hospital.
Bill, thanks for joining us. It's always
Welcome
good to
back.
have you.
It's good to be back.
So I'm going to take you way, way back to when we were young. And this is before your time,
Okay.
when there was serum hepatitis and infectious hepatitis.
Correct.
Now we've gone to the alphabets. Tell us a little bit about the evolution of the different hepatitides and how we got to hepatitis C.
Well, that was true. There was serum hepatitis, which nowadays would be considered mostly hepatitis B. Hepatitis A is still relatively common. That's a foodborne hepatitis, which almost always is self-limited, rarely causes severe disease. Hepatitis B is actually a huge epidemic, more in Asia than here, but we certainly see a lot of patients with chronic
And we're
hepatitis.
vaccinating babies
We do.
against that.
Everyone is vaccinated, at least in the United States, everyone is vaccinated, so it is a preventable disease. And hepatitis C, which used to go by the moniker of non-A, non-B hepatitis.
Typical medical jargon, right? I was just going to say that. Non-A, non-B hepatitis becomes hepatitis C.
We did not know. We knew there was something there, but could not identify it. And hepatitis C has a long history. It first emerged in Japan in the 1920s. The Japanese actually invented amphetamines around the turn of the century, and they were used in the war effort. They were used for a variety of reasons, often with multiple uses of a needle. And so they became an epicenter for hepatitis C. In the 40s and 50s in Egypt, the same thing happened with schistosomiasis, a parasitic infection. And again, they treated thousands of people with antimony with multiple injections. And in this country, hepatitis C started really about the 50s and 60s and was thought to be related to the IV drug use in the 1960s, but probably relates more to, again, needle reuse in hospitals, doctors' offices, because they didn't have disposable sterile needles. So the main part of our epidemic was in the 60s and 70s. It got into the blood supply. And if you trace out new cases of hepatitis C in the United States, when you get to about 1989, when the first assay the virus is identified and the first diagnostic assay was available, it just plummets. So the blood supply, they were identified, you could identify non-A, non-B was actually hepatitis C, and the rate of transmission dropped by 95%. There are still new cases. It's spread by body fluids and drug use, but it's a shadow of what it used to be. So we're really dealing with the people who were infected 20, 30, 40 years ago.
And as you said, it could be because they shared needles or body fluids.
Right.
I will remember, again, when I was an intern and even a medical student back in the very early 70s, we didn't realize the potential infectious properties of blood. And except for patients with known hepatitis, who we handled with caution, there was no such thing as universal precautions. I never wore gloves drawing bloods on my patients. Having blood-stained hands were almost a mark of distinction because it meant you were doing stuff.
Yeah.
And I remember spilling blood on myself. We used to spin our own hematocrits. And it was really the AIDS epidemic that brought us into universal precautions. So I suspect any healthcare worker from that era also had a high likelihood of exposure.
Oh, no, there were a lot of, there are a lot of healthcare professionals of that era who have, chronic hepatitis C. And unfortunately, I know a few have died of it.
And yeah, well, what is the course of chronic hepatitis C?
Well, as you said in your promo, about 3/4 of individuals who are exposed to hepatitis C will develop a chronic infection. The acute infection, either you don't know that you were infected or you may feel like you got a little case of the flu and it goes away in a few days. we have very little data on that. Most of that is healthcare professionals when they get a needle stick and we can track it. The vast majority of cases, someone's exposed, they don't know it, and about 3/4 of them rather will develop chronic hepatitis. It's an indolent disease. It doesn't cause symptoms, but the problem is in maybe 1/3 of those chronic patients, it will develop into fibrosis, scarring of the liver, ultimately cirrhosis, and ultimately increasing the risk of liver cancer. When I started seeing patients with hepatitis C in the late 1980s, when we did liver biopsies, the vast majority of our patients had early stage fibrosis. Now it is not at all unusual for a new diagnosis of hepatitis C to come in and see me who has established cirrhosis, and 5 to 8% of the patients actually have liver cancer because they've developed cirrhosis and they've developed liver cancer. So we're completely at the other end of the epidemic, and the people we're diagnosing now many of them will have advanced disease, hence the need to get out and identify these people and treat them before this happens.
Because they've essentially had a silent disease for decades.
And you know, this may only manifest as some very minor liver test abnormalities, and in the era of obesity in this country, we see a lot of abnormal liver tests because of fatty liver, and actually the norms have actually gone up. So some of this is not recognized by the patient, not even recognized by their doctor, that there's any abnormality at all.
And I guess we should point out that both fatty liver and chronic hepatitis C, they can lead to scarring. You mentioned fibrosis, extensive fibrosis we call cirrhosis, and once you have that liver damage, that puts you at a substantially increased risk for liver cancer.
It certainly does.
Are we seeing an increase in the rates of liver cancer?
Absolutely. It's the fastest
Because that used to be a very uncommon disease.
No, it's the fastest growing cancer in the world, because of hepatitis B elsewhere in the world and hepatitis C here.
And even if one does not go on to develop liver cancer, cirrhosis in and of itself carries a high burden of complications.
Oh, absolutely.
And
So
problems.
cirrhosis, once you have reached a stage of cirrhosis, it manifests by some changes in blood flow through the liver. That can become a self-perpetuating process. Even if I eradicate your hepatitis C, the scarring will reverse itself to some degree, but at some point, it becomes a self-perpetuating process, even though you've eliminated the cause.
And some of our viewers may be familiar with cirrhosis from other causes, for example, alcohol, but cirrhosis of any cause can be associated with things like fluid retention in the abdomen, with bleeding and bleeding in what we call varices around the esophagus and in the stomach. And really significant problems for patients.
Even kidney failure in its latest stages. It just
It's
can
a
be a
difficult
devastating
disease.
disease.
It's tough to treat, and ultimately the only cure for established cirrhosis is a liver transplant.
Yeah, I think we used to think of sort of the cherubic man with the rosy red cheeks and the prominent belly, a chronic drinker, and that actually is the sign, is the phenotype, is the look-alike of a guy that's got advanced cirrhosis.
Absolutely.
So it's not really as cute as we
No, it's not.
as we may have thought about it, our Christmas cards or whatever.
We do take care of a lot of it.
What is it about the viruses, hepatitis B and hepatitis C, that wind up causing fibrosis and cirrhosis?
They lead to a chronic inflammatory process. They're two very separate viruses. Hepatitis B is actually a DNA virus that gets into the host DNA. Hepatitis C is an RNA virus, but it triggers an immune response just like any virus, but it doesn't trigger enough of an immune response to eradicate all of the infected cells. Hep C does not appear to have a reservoir outside of the liver. So if you can cure the liver of the infection, it's not like HIV that's scattered all over the body that you can't get rid of. If you can cure it in the liver, it's gone. And we used to very cautiously talk about cure with hepatitis C. Now we use the word cure. If we can treat you with a variety of medications and you are virus negative 6 months after completing therapy, your chances of a spontaneous relapse of hepatitis C is about 0.1% at 10 years.
Wow, I didn't know it was that
So
good.
so if you can get to that point, and with today's drugs, we can often get you there, we can cure this.
And I think that's one of the most exciting things in medicine in the last several years, right? We had this disease that was chronic, that there was
really
little that we could do about the treatments that we had were often associated with terrible side effects that made the treatment completely intolerable. And now, in the last several years, we're talking about the word cure. I think it's remarkable.
We started with interferon as a 3 times per week injection.
In the
for a
old
year,
regimen.
In the old regimen for 48 weeks with about a 15% eradication rate at best. It then switched to what's called pegylated interferon, which is a depot injection, so you only had to inject yourself once a week, but you felt crummy all week. And that had maybe a 20%. We added an oral drug called ribavirin that brought it to 35 to 40%, and that's pretty much where things stayed until the advent of what were called protease inhibitors, and there were 2 telaprevir and boceprevir that came out in about 10 years ago, 8 years ago, and were added to interferon and ribavirin, and that, we were thrilled. That brought it up to like 60%, sometimes 70%. But it was a pretty toxic regimen. And we no longer use telaprevir, boceprevir, rarely use interferon, and all of the regimens nowadays are oral, and usually completed within 12 weeks.
And this, again, Andrew was saying, is one of the most exciting things to see. Not too long ago, the paradigm in medicine was that viruses aren't treatable.
Correct.
That we had antibiotics that took care of many bacteria, but when it came to a virus, anywhere from the common cold to hepatitis C to HIV, we didn't have treatments that were effective. And now we really are developing treatments for a number of these serious viral illnesses to the point where we're curing hepatitis C and certainly controlling HIV indefinitely, maybe curing it in some instances. But it's really an exciting next step.
Oh, it is. We're also controlling, it's a totally different topic. We have 2 drugs that are very effective at suppressing hepatitis B, and there are some new drugs under study where there is thought about actually curing hepatitis B as well. Probably 10 years off, but it's very exciting.
And with all that comes the ability to prevent things like cirrhosis and also prevent cancers.
Absolutely.
Which is
And
just
thus coming to this new recommendation from the CDC that all of us baby boomers, as you said, between ages 45 and
Born in 1945 to 1965.
Be tested. So, because well, you finish my sentence.
Because of the fact that it's asymptomatic, and you may not have significantly abnormal liver tests, or they may fluctuate and be normal at times, which is how a lot of the blood supply got contaminated back in the 60s and 70s. It's been advocated that you take these high-risk individuals just by virtue of when they were born, having nothing to do with their behavior, their activities, and say, just by virtue of being in this age cohort, you're at risk. So we'll test you one time for hepatitis C antibody, and if positive, we do some more sophisticated testing, and then if you are indeed carrying the virus, refer you for therapy. And that has met with a lot of success, and I think I see a lot of patients who are picked up this way, and they're grateful to have been identified.
I think that's a great way to end this segment, this first segment of the show, and we're very much looking forward to talking to you more in the next segment.
A little bit about how do you get screened, and how do you actually treat the disease now. But it's really, this is another example where viruses have contributed to cancer, and we can prevent. By preventing the viruses, we can prevent the cancers. It's really little steps, but it's great. So I want to thank Bill, and we'll be back after a short break.
Don't go away.
Hi, Andrea and I are back with Dr. William Hale. Bill?
Bill, welcome back. So we were talking at the end of the last segment a little bit about testing and screening for hepatitis C. Maybe you can start us off there.
Sure. Actually, testing for hepatitis C is quite straightforward and easy. It's a simple blood test where we look for hepatitis C antibody. Your body's immune system has reacted to the virus. It just hasn't reacted enough to actually clear the virus from the body. The antibody test is very accurate in the sense that it'll pick up almost everybody who's been infected. It picks up some false positives as well, and I get referred people on a, not a regular basis, but several times a year who have a positive antibody, no exposure history. And we do what is called a viral load. We can actually measure the virus in the bloodstream. And those people will test negative, and it's just a false positive laboratory test.
So if a negative viral load won't fluctuate over time, so a negative is negative.
A negative viral load is a negative viral load. So we test an antibody. If the antibody is positive, you then move ahead and have a viral load tested.
Which is another blood test.
Just another blood test. If the viral load is positive, we then break it down. We look at the genotype. There are 6 particular strains of hepatitis C in the world, 3 of which are relatively prevalent in this country. A couple of them are seen in, one's seen in Egypt, and a couple more are seen in Southeast Asia. So we break it down because treatment does differ a bit depending on the strain. And once we have that information and some routine blood work and some imaging of the liver and often a test of liver scarring to determine whether you have advanced scarring or no scarring, we can then come up with a treatment regimen very quickly.
I think it's important to point out, too, that just because you've had a blood test doesn't mean your doctor's checked for hepatitis C. It's not part of a routine panel. You just have to make that.
It's a specific test for hepatitis C antibody.
So again, if you're born between those years, you should ask your doctor whether you've been tested, and if you haven't been tested, should be tested, because you can prevent cirrhosis and even worse later on down the road.
Absolutely.
But if you're in that age cohort and you've had a negative test, you're good.
You're done.
As long as you haven't had any other exposures.
Correct. As
you're
long
done.
as you've not been exposed since you've been tested, it's not something you're going to pick up from the air, water, food, or anything like that.
And you said right now our blood supply is all tested,
Yes.
our needles are all reusable. I'm sorry, our needles are not reusable.
reusable, sterile.
Reusable. How about active drug users now who are using needles? Is Hep C circulating in their community?
It is, and there has been one study with a drug called Zepatier, which came out about a year ago, where they actually looked at the effectiveness of treating active drug users who had hepatitis C. And they found 2 things. Number one, despite the active drug use, the people were compliant and took the drug and could be cured of hepatitis C even if they were still using drugs. But I think as importantly, their viral load, the measure of virus in their blood, dropped to 0 very quickly, so that even though they were continuing to use drugs and share needles, they were not infecting anyone. So the risk of spread of the hepatitis C virus from that person into the community dropped dramatically, and they were ultimately cured.
Let me ask a question, may or may not be known. If you have been exposed to hepatitis C and been cured or cured yourself, are you subsequently immune to hepatitis C?
Doesn't appear so. And the basis for that is all patients with hepatitis C have circulating antibody, and yet they still have active hepatitis.
So our immune systems just aren't made to eradicate this virus?
Not without help. But essentially you need a drug to suppress the virus to very low levels, at which point it appears that the immune system can eradicate the small remaining virus that's there with drug therapy. Or you can boost your immune system dramatically with the use of interferon and eradicate it. But absent those 2, your own immune system generally will not do it.
And interferon, it's got a great name. It's been probably one of the first, if not the first, antiviral that was out there. But it is a toxic drug to use. It makes people, it's the same chemical that makes you feel like the way you feel when you got the flu.
Yeah.
Right.
You feel like you got the flu all the time.
For a year.
Yeah, it's tough.
Because I've used it in hematology. It was one of the first treatments for a certain hematologic disorders, and it was unpleasant for the patients. Effective, but
It's tough on the doctors. A lot of phone calls.
Exactly. So tell us a little bit about the treatment. You know, what's it like? Few pills, and then what? I know there's some problems, particularly with cost. So we should talk about that too.
Yeah, the pills themselves. There are 3 classes of drugs. There are what are called protease inhibitors. The 2 I mentioned earlier, telaprevir and boceprevir, were the first of those. They're first generation. They're not used. The second generation PIs are better tolerated and more effective and have less resistance. Then there are what are called nucleoside inhibitors. Sofosbuvir, made by Gilead, is the biggest one. There are others, but that has been the biggest one in use. And then there are what are called NS5A inhibitors made by several different companies. So most of the treatments will include either a PI and an NS5A, or an NS5A and a nucleotide inhibitor, or sometimes all three. It depends. We'll sometimes
It's really, just for folks at home, attacks the virus, replication, et cetera, in 3 different ways.
Correct. They all work in a different stage of the viral replication.
So you get a certain synergy. It's one of the principles I think people are using in cancer too, to try to attack the cancer cell at various parts of the pathways that are activated.
Yep.
And just to mention, people may have heard similar words used in medications used to treat HIV.
These are similar drugs to HIV. None of the HIV drugs work for Hep C, but it's the same concept, that you block the viral, the replication cycle of the virus is blocked at several points.
And so you're using several drugs of similar classes, maybe, to treat different viral infections.
And finally, the viruses each have similar ways, or often have similar ways of getting into the cell, of either getting into the DNA, hijacking the cellular machinery to produce more of themselves. So it's a different approach than we've had with bacteria. How long is the treatment?
It varies. Standard treatment would be 12 weeks, usually 1 pill a day, 12 weeks. There are studies ongoing, and there are studies that have shown that with certain combinations, you can, an early stage, relatively low viral load, you can treat in 4 weeks, 8 weeks. There are studies looking at 4 and 6 week therapies, so the goal is to try and get this treated as quickly as possible. 12 weeks still is the standard therapy. If you have cirrhosis, particularly if you have well-established cirrhosis, we often extend the treatment for 24 weeks, but no one gets treated longer than 24 weeks with the currently available drugs. So 8 weeks, some people, 12 weeks, the vast majority, 24 weeks, a small number of people.
Why do they extend the therapy in the cirrhotic patients? Because they don't want to be wrong?
No, the problem is and this became actually quite a big issue early on when these drugs were first being made available, and they were a single treatment course was $180,000. So there was push from the insurance companies to restrict the use of these drugs to more advanced stages. Somebody had to prove that they were going to develop advanced disease, and then we would treat them. The problem is, number one, we're not that good at predicting how fast that's going to happen to someone. And number two, you lose 10 to 20% of efficacy when someone has established disease. So it's much easier to treat someone who has minimal fibrosis than it is to have someone who has cirrhosis. And whether that has to do with the host, the person, and their immune system, whether it has to do with scarring somehow protecting the virus, or whether it shows that this is a more aggressive virus because it produced all this scarring, I don't know. But early stage is much easier to treat. So there was a big push saying that that's actually cruel to do that. So we treat everybody now, all comers.
We only have a couple minutes left in the show. I just wanted to make sure we could ask for viewers who might be thinking about getting tested but might be worried about having to take these medications, how well tolerated are they?
They are, well, certainly coming from someone from the interferon era, they're extraordinarily well tolerated. With the standard drugs that we use, some people get a bit of a headache, which usually goes away in a couple of weeks. Mild, can be treated with Tylenol or something like that. The occasional skin rash, some muscle aches. In my experience, I would say easily 80 to 90% of the patients have no idea they're taking it. I could be giving them placebo. They have no sensation from the drug whatsoever.
So people are working, doing their daily activities, and fully involved in their lives while they're going through this course of treatment, which is potentially life-saving.
Absolutely. One interesting thing came out just recently at the liver meetings, looking at even early stage people, that they have good documentation now that there are cognitive effects, fatigue, difficulty concentrating, that has to do with hepatitis C viremia. No one's quite sure of the mechanism, but that if you
That means
take
the virus in the blood.
virus in the blood. So if you take these individuals and do psychometric testing and put them on drug, even before they're cured, but the viral load is down to 0, there's a dramatic change in how they feel. So many people actually feel better on the drug just because the virus load
Only
is down.
15 seconds left. Are there any vaccines on the horizon
Yes.
for it?
There are. They're ways off, but there still is a lot of enthusiasm for a vaccine to
Good.
prevent this from
And maybe in the
happening.
high-risk people like healthcare
Yes.
workers. Well, that's all we have time for. Thank you. That's really a very, very important topic that I think people that
Absolutely.
may not understand at home or not heard much about. When we come back, we'll have today's health question, also liver-related.
Right now, let's take a look at some of the upcoming events sponsored by Western Connecticut Health Network.
Hi, this week's health question is, and it's not liver-related, what are the risk factors for colon cancer? So it's still a GI question.
Absolutely.
So Bill, tell us, what are the risk factors? It's a common disease, but in many ways preventable, right?
It's preventable by identifying polyps and removing them. Risk factors, certainly heredity, first-degree relative, even a second-degree relative, as some recent data has shown, increases your risk, not dramatically, but it definitely increases your risk of developing colon cancer. Age, colon cancer rises with age, so we generally start screening people at around age 50, and then every 5 to 10 years thereafter. And a Western diet, heavy in saturated fats, not so heavy in vegetables and fiber, is also a well-recognized risk factor. So eating for your heart will actually protect your colon as well.
And I know people have been using aspirin to reduce colon polyps or drugs like aspirin. Where's the status of that?
The data is soft, but there. Low-dose aspirin, the 81 milligram that people take for their heart, does seem to have some effect on the development of gastrointestinal cancers, colon polyps, colon cancers, and even there's some data with esophageal cancer in the setting of Barrett's esophagus. So I think that low-dose aspirin, if your cardiologist or your internist thinks it's a good idea from a vascular standpoint, I think it's an excellent idea from a GI standpoint.
But the best thing you can do to prevent yourself from having advanced colon cancer or dying of colon cancer is to get screened.
Yes.
And
Absolutely.
with 30 seconds, I know there are a variety of screening methods out there, from the DNA one that they advertise on TV to the colonoscopy every 5 to 10 years. What are your thoughts on the different screening methods?
Well, there are two anatomic screening mechanisms where you look at the entire colon. There is colonoscopy, which is certainly the most invasive, but it allows identification of polyps and then removal of polyps, interrupting the polyp to cancer sequence. So it is both diagnostic and preventative. There is
10 seconds left.
CT colonography, where you take a CAT scan of the abdomen, which is diagnostic. And then there are various fecal tests, which can tell you your risk of having colon cancer, not so much colon polyps.
And we have to end it there. So on my choice, I'll do the colonoscopy, even though it has the least pleasant side effect. So if you have a question you'd like to ask on Health Talk, please contact Andrea and me at healthtalk@norwalkhealth.org.
We'd like to thank today's guest, Dr. William Hale, so much for coming on our show and sharing very important information with us.
So we'll see you next week on Health Talk.
Be well.
And if you're a baby boomer, get tested for Hep C. Bye-bye.